Hi, my name's Sam Bishop, and today I'll be talking about opioid-induced hyperalgesia in former athletes for my opioid project and how all that will relate to physical therapy. So I just kind of wanted to start with some background information and like prevalence of this condition, as well as just opioid use in sport as well. So opioid use is prevalent amongst both amateur and professional athletes. A study found that approximately 4.4 to 4.7% of all athletes have used opioids at some point, whether this be just for like a temporary, like acute type injury or for more of a chronic pain type. That was not specified. Um, but out of all sports, the sport that has done the most research or has published the most articles on opioid use is the NFL. They've been really focused on trying to crack down on some of their health metrics and stuff like that. So there's one study that said that basically found that opioid use during an NFL player's career is predictive of continued use post-retirement. If you used opioids throughout your career, you have about a 26.2% chance of using them post-retirement compared to a 7.1% chance if you did not use them in your career. Another study found that opioid use post-retirement increased the likelihood of moderate to severe depression and lower health-related quality of life. And that health-related quality of life can be anything from chronic pain or depression or other mental conditions. It's more of like a overall statistic to judge how well someone is doing. And again, uh, contact sport athletes are at a higher risk for use of opioids, and these contact sports mainly include football and hockey and rugby. And as for some statistics about opioid-induced hyperalgesia, it's a fairly uncommon condition. There's a study done on physicians and how often they see people with opioid-induced hyperalgesia. They found that for acute pain patients, they have a prevalence rate of 0.002%, and if chronic pain patients, it's about 0.01% per physician per practice year. So it is a very, very uncommon condition, but it can be pretty devastating to a person who is suffering from it. As far as current treatment options, it's usually more of a pharmaceutical approach. So what they like to do is add what they called opioid adjacent or analgesic adjacent type drugs, such as ketamine, COX-2 inhibitors, or gabapentinoids, and kind of decrease that opioid. So what happens with opioid-induced hyperalgesia is that a patient usually builds up such a tolerance, typically through misuse. Well, that it's not always the case. That is the majority of cases. And whenever you start taking that opioid away to try to decrease that tolerance, they end up having withdrawal symptoms, which could be worse than the hyperalgesia. So to try to combat this withdrawal symptoms, they give them a mixture of drugs, like such as ketamine, COX-2 inhibitors, or the gabapentinoids that kind of act as an analgesic to kind of fill that gap that the decreased opioids left behind. As far as why this is relevant to physical therapy, there's been multiple studies that have found that former athletes have a higher prevalence of chronic pain and osteoarthritic conditions than the general population. And physical therapy has been proven to be effective at treating these types of conditions. So basically what that means is that there is a strong likelihood that we as PTs will evaluate and treat former athletes with either chronic musculoskeletal pain or osteoarthritis. And while the condition is uncommon, we may encounter opioid-induced hyperalgesia in this population. And we should know how to treat it, manage it, and basically educate the patients. As far as the clinical application goes, the first bullet point on this slide I think was incredibly interesting. There's a study done, it was not on humans, it was just an animal trial. I believe they used rats. But they had secondary and primary induced hyperalgesia. Primary being more of just like musculoskeletal pain, secondary being like a secondary pain or secondary increased pain post exercise. So what they did was they altered duration times of physical activity for these rats. They basically ran them through like obstacle courses and had them on wheels for extended periods of time, and they monitored the effects on the muscle tissue and like their pain sensitivity throughout the next couple days. So they found that secondary hyperalgesia, of which opioid-induced hyperalgesia kind of falls under, um, it actually reduces the effects of it. They said that if you get on a routine of about 5 days of doing these shorter duration physical activities, the effects will basically naturally taper off due to higher levels of serotonin in the body. They did find, however, that if you exercise or have physical activity for too long, that will actually exacerbate the symptoms, and the rats were found to be in more pain. While this is not a human trial, I think this can be applicable to humans in a way, especially from a physical therapy standpoint, as we can kind of monitor how our patients are doing and keep the exercise times at a minimum to avoid that kind of exacerbation of the hyperalgesia. Um, and it's one of those things where it might be a little bit of a trial and error type situation where we have to find that perfect window where we're getting enough benefit from the exercise but not overdoing it to cause excessive pain. Additionally, the patients, as far as education goes, patients were found to be very supportive in a study done that physical therapists should educate them on the dangers of opioid misuse and related conditions. They were very receptive and positive to physical therapists explaining what happened with them, with their condition, and potential side effects or dangers or symptoms they may have in the future. Another thing that was found was that personalized patient handouts were effective in both improving patient knowledge and almost like creating a level of comfort for the patient with their condition. And this should be implemented, especially because opioid-induced hypoalgesia is not common, and these patients would benefit from these additional resources.